Hi, welcome to Table Talk, and thank you for joining us. Today's guest is Dr. Robert Christenson from Ascension Saint Thomas River Park to talk to us about Colon Cancer Awareness Month. Welcome to the show.
Thank you for having me.
Yeah, happy to have you. We've had some great doctors in so far from Ascension Saint Thomas, and our audience has learned so much, and so have I. So tell us a little bit, introduce yourself to our audience, and what made you decide to locate to McMinnville, Tennessee.
So, as you already said, Dr. Christenson, we moved here in 2021, my wife and two kids, two boys, they're now 9 and 11. And general surgery, I was out in New York doing general surgery there. We moved, like I said, in 2021. We all kind of know what happened in 2020. And so we got a full force of it. And it was never really our intention to stay in a bigger city. We always wanted to go somewhere a little bit more rural. And as COVID came through, we really kind of felt the push that we wanted to relocate. So we started looking for job opportunities just all around the country, really. We've lived all over. Our family's all spread over. Both my wife and I have big families, and there was no one place that was really where we had to go. So actually my wife had, at the time, one brother who lived with his family in Knoxville.
Okay,
and so,
yes.
And they've got 4 boys, so they were sending pictures of all the hiking they were doing, and we love being outdoors, and we said, that looks great, and we looked that way. And so we were looking around, the job posted here at St. Thomas River Park, and so we came and interviewed, and the first people that we met here were just some from the community that we stayed with, and we loved them, and they were just awesome people. And so pretty much really it came down to is like we liked the area, but the people just seemed great, so figured we would make that work. And since we've been here, we've loved it. There's not really anything that we feel like we miss so much. Lots of people say you can go not too far to get to any bigger city if you need to, and my response is usually, yeah, I mean, when I was in New York, we didn't have to travel far to get anywhere. It just took forever to get there.
Yes.
So
You'd almost rather travel on the open road versus gridlock in traffic.
yeah, it's a lot prettier. So we've thoroughly enjoyed it. So we live here in McMinnville. I love being close to the work so that even when I'm on call at the hospital, I don't have to necessarily be there, and I can be at home and do stuff with my family. And then if something's at the hospital I need to go and check on, it's just a short trip.
Yeah, we don't have a large commute time here. Usually about the furthest out is 30 minutes, and that might be the far reaches of the county. So we appreciate that as locals ourselves. So I see what the draw is. And plus, as you said, the mountains, got lots of water and things to do here. So it is a great place. Let's talk about March being Colon Cancer Awareness Month. Tell us first, I guess, how colon cancer can develop and what some of the symptoms are.
So colon cancer, we kind of lump colon and rectal cancer together when we talk about colorectal cancer. It's still the number 2 most common cancer-related death of people in the U.S. Number 1 for men and women combined is lung cancer.
Wow,
So number 2 being colorectal cancer. Colon cancer in itself takes up about 70% of that. And the other 30% is rectal cancer in of itself. It's common. It's extremely common. Probably about 1 million people in the world at any given time have colon cancer that they're dealing with. And it's estimated probably, at least current statistics say that it's probably about 23,000 people will die from colon cancer here in the U.S. this year. So the development is very subtle. Colon cancer, rectal cancer, for the most part, there's very few exceptions in terms of rare or more rare kinds of cancer. But for the most part, colon and rectal cancer is a very slow grower. It's very slow to progress. You don't notice anything until the symptoms, when you start to develop symptoms, tend to suggest that maybe there might be something more advanced going on.
Okay.
Symptoms that you usually want to pay attention to, things that we talk to patients about, will be things like abdominal pain that's not explained in the sense that you haven't worked out or identified other things going on. Bleeding, if you're seeing bright red blood or maybe black blood in your stool, or particularly if you're having painless bleeding when you have a bowel movement. I know it's not fun to talk about. Nobody really wants to talk about those
Well,
things. They
it's
don't,
part of life, though.
but they're things you have to pay attention to.
Right.
And other things that usually warning signs for cancer in general are things like unintentional weight loss or weakness or anemia where your blood level's low and you haven't identified why. Those are all kind of warning signs of things you need to watch out for. But any of those kind of things are things when you need to go and talk to your primary care doctor and say, hey, I'm having these things going on, even if it's uncomfortable and you don't want to talk about it, you need to.
Right.
And then it's really their responsibility to decide is that something they need to refer to a specialist to work up.
So how does colon cancer develop? Like, is it cells that start going awry? What is that?
Cancer in itself is really just a cell that doesn't know how to stop. So almost all our cells in our body are designed to reproduce. There's lots of turnover. Cells in the body that have higher turnover are things that are going to be a higher risk for cancer because they're constantly reproducing themselves. So skin cancer, if you think about skin cancer, your skin is constantly turning over.
Right.
Colon cancer and colorectal cancer, you're constantly moving things through your intestines. And so those cells are constantly having to reproduce. And every single time a cell reproduces itself, there's always a chance for mistakes. And if one of those mistakes is something that tells it to stop reproducing and only do it at a certain rate, and then it starts to grow too fast.
Okay.
And that's really what cancer is. It's just something that doesn't know how to stop. And then the more frequently, the rapidly it changes, then you start to have other things that potentially can go wrong. So colon cancer, rectal cancer, same story. You just have a spot, a single cell that had the right kind of or the wrong kind of changes, and then it just continues to grow, and it gets bigger and bigger and bigger until it either outgrows its own blood supply and it starts creating ulcers and bleeding, or it starts pushing on things, and then you start having blockages or obstructions or things like that.
Okay, very good to know. So you mentioned kind of the differences between colon cancer and colorectal cancer. Kind of talk about that just a little bit more.
Sure. So it's a good question. Colon cancer, as I mentioned, and colorectal cancer is essentially lumping the two together, but the devil's in the details, really. The difference between colon cancer and rectal cancer isn't so much in terms of the development, it's really the treatment.
Okay.
We handle the treatment for colon cancer and rectal cancer differently. Part of that is that your colon isn't necessarily fixated in all of the places in one specific location, and it's all throughout your belly.
Right.
Versus rectal cancer is in one spot. And so the other problem is that rectal cancer is very close to the end. And so when we're talking about trying to resect out a portion of cancer, if that's what we come to, you can't go too far before you
Yeah.
run out of distance.
Right.
So the management is different, treatment plans, but there's lots of kind of specifics that go into that depending on which one you have.
And I
But
guess you could have both. Is that
You
sometimes
can.
part of it?
And there's the gray area between the end of the colon versus the rectum. That's kind of a gray spot. And really, when it comes down to cancer being in that location, it really is a discussion between you, the specialist, oncology, about what kind of treatment options you have and what you want to do for that.
Okay, so, we've heard many times how important screenings are and how they do save our life. And as you had mentioned, I guess in an email back and forth, we talked about 50 was the number, but now they've kind of pushed screenings back to 45. Talk to us about why it's so important for us to start at that point in our life, and maybe what are some of the different types of screenings?
So, the age did recently change. Back in 2021, I think the U.S. Prevention Task Force changed that as the official recommendation to start at the age of 45 for colorectal cancer screening. It used to be 50, and that's really statistics driven. So even some organizations like the American Cancer Society changed the recommendations even as early as 2018. But it takes a while for everybody to kind of get on board to all agree at the same, what the right number is going to be. And again, it's still statistics. Most people who are going to develop colorectal cancer will be after the age of 50, realistically. But that is dropping. It's getting younger and younger, and we're seeing it still. Since screening started, even just a couple decades ago, we've seen a decline in terms of the mortality of colorectal cancer. Now, that's different than saying the diagnosis. We're still seeing it just about as frequently, But the
Okay.
number of people who are dying from colon cancer is decreasing. And that's because we're catching it sooner and we can take care of it. One of the most common screening things we do is colonoscopies, like something I do at the hospital, as well as some other general surgeons. Most of the U.S., you're going to see a gastroenterologist that's going to do a colonoscopy. But the screening there is really important because if you have something that's a precursor that we can see, we can do something about it at the same time, assuming that it's like a small little skin tag kind of thing, which we call polyps, versus maybe a smaller, more of a lump kind of lesion. But we can visually identify that, and then we can usually get rid of it at the same time. In very rare circumstances, you may even have somebody who has cancer in a polyp, and because we're able to take it off cleanly, they're essentially cured of that cancer because they got it taken care of early enough.
And while you're performing the colonoscopy, you would go ahead and do that? Is
Correct.
that correct? Okay, so then there's not a need for, if you see it then, there's not a need for a second surgery,
That's
hopefully.
correct. And that doesn't happen all the time, but it does happen. The other advantage is that if you do identify something that's cancer, you can biopsy it when you're there, and then that gives you that first step you need to know what kind of thing you're dealing with. Because there are some variables, specifics, or different things that change how we manage the treatment plans.
Well, I know, a lot of people joke about the dreaded colonoscopy, and really the worst part of it is the drinking of
It's the prep.
it's the prep that has to go
Yeah.
into it and stuff. But, I'm sure the traditional prep is still ideal, but now there's some ways I think people can do that at home now. Is that correct?
Preps generally at home, and everybody kind of has their own way of doing things. Some people like to use certain mixtures or medicines to do a prep. When it comes down to it, if you're going to do a colonoscopy, you need to be empty. And there's no real nice way of doing that.
Right,
so
right.
whatever medicine or method you'd use, it's not going to work for everybody. Not everyone's going to do well, and nobody enjoys that.
Yeah.
But the end result is necessary to get you cleaned out so you can see what you need to see. And if it's clean and you don't have any problems and there's no other risk factors, then you're good for 10 years. There are other ways to do screenings. You can do just a test of your stool for blood, and you can do that annually. You can do a Cologuard test is a common name brand one now that is a genetic test. You still have to test your stool, but it's testing the cells in there for certain markers that are concerning, or for blood. You can do a CT, you can do a barium enema. The CT or CAT scan, as a lot of people call it, has to be specialized, and not everybody offers that as well. But all of those things are more frequent. So even if you would do like a Cologuard test, that has to be done essentially every 3 to 5 years, maybe even more frequently, depending on your risk factors. And we talked about the age being 45 to start, and that can be different for some people. Now, if you have certain pre-existing conditions like ulcerative colitis or Crohn's disease, or certain genetic mutations, then you may need to start sooner. Or if you have family history, if your mom or your dad or your brothers, sisters, anybody that's a first-degree relative, they have colon cancer, you really should start 10 years younger than their diagnosed age. So if you had a brother that had colon cancer when he was 46, then you should start screening at the age of 36,
Okay.
just because you're at higher risk. And the relative risk of doing a colonoscopy versus the benefit, if you're able to identify something in an early stage and get rid of it, is phenomenally different. So it's always worth the risk, and it's worth the trouble of going through of doing a prep or doing your screening just to prevent something from happening
right.
that is completely preventable.
Right, exactly. I mean, it's so almost, we know people have different aversions to medical procedures and things like that, but the one on the front end is so much easier than having to fight cancer or the things that happen on the back end with chemo and radiation and that kind of thing. So talk to us too about the risk factors. I guess, you mentioned genetics and things like that, but I know as a society, we're not the greatest eaters. Does that kind of play a part, I guess, in our risk?
Realistically, it's a multifactorial thing. Just from living in the U.S., everybody generally starts off with a 9% chance of getting colon cancer in their lifetime, and that's statistics. If you live outside the U.S., that's different. Like, for example, some countries, they screen for stomach cancer the way we screen for colon cancer because
Okay.
it's so much more common there.
Uh-huh.
So it's probably multiple things. Now, there's some things that obviously increase your risks beyond the baseline. And we talked about family history or genetics being an issue. But lifestyle is definitely going to make a difference. Some of that may be healthy eating habits. We already know that good fiber in your diet makes a big difference because it decreases the amount of strain on your colon. And what you're trying to avoid is anything aggravates the
Okay.
normal process of what's going on. Other things, we talk about trying to control diabetes if you're diabetic, and smoking. You're not going to find a single doctor who's not going to tell you shouldn't smoke, right, for some reason or another. All those kind of things just increase your chances of having colon cancer.
Okay. It seems like that is our diet, and our exercise is just the magic key. It seems to be the hardest one for us to open the door with, but
But that said, it doesn't matter. I mean, if you could be the healthiest person and have the ideal body weight and live your life without any smoking
True.
or drinking, and you still have a risk of getting colon cancer, and you should still get your screening
still
done.
get those screenings done, yes. So if you have a patient that has been diagnosed with colon cancer, what types of surgeries? I know you're a surgeon, and so you're probably the one that's going to be performing. What types of surgery do you do with a diagnosed patient?
Well, colon cancer in of itself, surgery is pretty much a little bit different depending on where in the colon it is, but otherwise it's generally the same. Let's assume that someone gets diagnosed with colon cancer based off of a colonoscopy. They came into the hospital, they were seen by their physician, and they had anemia, and they didn't know where it was coming from. So they get a colonoscopy, I do a scope, and I find that they have cancer. And so the next steps would be a workup with some blood tests, usually imaging. We need a CAT scan to make sure that there's no evidence of metastases anywhere else in the body. We don't like talking about that. A lot of people don't feel comfortable with concepts about having stage 4 cancer when it's diagnosed, but realistically, 20% of people who are diagnosed with colon cancer will have a metastatic lesion. And so we need to screen for that first, because as long as the patient doesn't have an urgency to doing a surgery, if they do have metastatic disease, then they get treated by an oncologist with chemotherapy
Right.
first,
Okay.
just to try to take care of those lesions and to help better, to make your resection better. If there is no evidence, then surgery is the upfront treatment at that
Okay.
point. Most of the time we can do this laparoscopically now, or laparoscopic assisted. So you're ending with small incisions and maybe just one incision that's big enough to get the mass and that part of your colon out. And then the recovery tends to be a lot better. If it's a complicated situation, someone has lots of other health issues or maybe problems in their belly, if it's not an emergency, they may end up with a slightly bigger incision. But handling an elective situation is always better. Now that's different than rectal cancer.
Okay.
So colon cancer, resection, if there is no lymph node involvement and there's no metastases, then they're done. That's it. There's no chemotherapy. There's no further treatment. It's just the resection. They stay on a close monitoring for a period of years afterwards, where they start getting repeat colonoscopies at a very short period of time, and then that gradually spreads out. But you can cure colon cancer if it hasn't spread anywhere just by cutting it out.
Okay.
And so that's where early detection is so much better, because then you can avoid the other treatments that people don't enjoy, which, chemotherapy has come a long way, but it's still
Yes.
chemotherapy. It still is not a pleasant experience in the
Right.
end. Rectal cancer, again, that really just comes down to how close you are to the end. Most of the time, if there's any evidence of it having eroded outside of the rectal wall itself, they'll get treatment with chemotherapy and radiation first. And that usually is because it makes the resection better. You have better results and better chances of having a long-term outcome that is not going to have any recurrence.
Right. Okay.
Now, and if you get all the way down to the end, then that's a conversation to have with a specialist, because that kind of surgery usually means having a lifelong colostomy at that point.
That's what I was going to say, maybe a bag or something of
Yeah.
that nature. So, which that's still, people still live with those every day.
They do.
And it's a great survival tool for those that have gone through that.
Yeah, and it's nothing to be ashamed of at all. People end up with colostomies for multiple reasons, and it's very uncomfortable. Lots of people don't like the idea of it, but realistically, it's better than alternatives, and it can be very manageable. And a lot of times you don't even know that someone has a bag. The person who has the ostomy is obviously a lot more self-conscious about them,
Right.
but other people a lot of times don't know, they can't tell. And if you have an emergency situation where you do end up with colostomy, say for cancer that's detected in an emergency situation, a lot of times that can be reversible.
Okay, that's good to know too. So if a patient is experiencing some symptoms, or are in that age range where it's time to start, how do you start the process, I guess? Is that with their regular MD, or can they call, how does that work?
Well, there's not really a bad way of doing it as long as you're doing something.
Okay.
The first person you can always talk to should be a primary care physician. Now, if you don't have one established, you can always go to a fast pace, for example, or urgent care, health department, whoever that you need to reach. Because there can be some basic, simple tests that are done first. Again, the things that you're looking out for is maybe bleeding that you're noticing with your stool that you didn't notice before, or dark or black stools that are coming out, or this abdominal pain, or weight loss that's unintentional, and or you're having that accompanied with excessive weakness.
Mm-hmm.
Those are things. Those are things that you should be talking with your primary care physician and mentioning to them. Usually, at that point, they'll make a referral, particularly depending on your risk factors or your age, and say, have you been doing such and such things? Like, for a woman, you should be getting a mammogram, right? That's
Mm-hmm.
kind of a normal thing you should be doing as well. If you haven't had a colonoscopy recently, or ever, then they'll be referring you to someone who can do the scope for you. Most of the time, if you have concerning symptoms, you're beyond that point of doing the alternative screenings. You're not going to just get a stool sample
right.
or a CAT scan for looking for any lesions. If there's concern that something's there, you're going to go straight to the colonoscopy. And it may be that it's nothing serious,
Mm-hmm.
but you would much rather know that. And if it is something that is serious, you'd much rather catch it sooner rather than later.
Right. So, as somebody I've had a colonoscopy because I had a bout with colitis several years ago, but I guess even if you've had one, how frequently, you mentioned 10 years, if you've had symptoms or you've had colitis or Crohn's or something like that, should you step it up and do it more frequently?
Yeah, 10 years is going to be if there's no other existing conditions apart from the fact that you're a human and you live in the U.S.
Mm-hmm.
So that's a 10-year scope. If you have a normal colonoscopy, or maybe you had some slight changes, let's say, for example, you had a bout with colitis, you got a colonoscopy, there weren't any polyps, there weren't any abnormal lesions, it was just an isolated incidence of colitis, or maybe you have some diverticulum, which is something we talk about sometimes. I see that frequently. Then that's it. You're okay. You can have another scope in 10 years.
Mm-hmm.
If you find polyps, or if there's something more abnormal, maybe you're in a 5-year interval. Or if you had a positive Cologuard test where you have genetic predispositions or some kind of warning signs or other factors, then maybe you're at a 5 or a 3-year interval. If I found something that was a lot more concerning, or maybe a lot of polyps, then you may be, okay, I need to see you back in 1 year.
Mm-hmm.
But then
Okay.
after you get the next scope, that may get spaced out again.
Right.
You're just trying to make sure that if you caught something early, that it's not something that's a trend that you have to keep an eye on.
Right.
And then if, say like you had some polyps and I said, we need to know that scope in 3 years, and then 3 years later you get a scope done and it's normal,
Then
then
you
you can say
space
you
it
can go out
out.
to 5 to 10 years potentially.
Mhm.
Just depends on what all the specifics were. And that's a responsibility of the specialist to be able to advise you what the best course of action would be.
And the nice thing is, I'll mention that you are here locally. You're at Ascension Saint Thomas River Park, and people, our audience, whether you're in Warren County or a surrounding county, you don't have to go to Nashville or Murfreesboro or Cookeville to have this done.
That's correct. In reality, for most of the routine care, we can take care of it here, and you shouldn't have to travel far to get it done. I go up to Smithville a couple of times a month to help out there as well and do procedures for people who don't want to even travel down here to River Park to do it. And that's understandable, but when it comes to your health, you should be willing to travel as far as you need to get
Right.
the right kind of care. And if there are some extenuating circumstances, there's some major concerns in terms of your health, things that it would be in your best interest to have it done in an institution that has more resources, then we'll advise you accordingly.
Yeah, right. Well, with we heard of so many rural hospitals closing several years ago, and we're so fortunate to have you all as a resource here locally for us and those in the surrounding counties. So thank you so much. And we appreciate that you've chosen McMinnville to move to and bring your family and raise them here.
Well, it's our town now, and it's our pleasure to be here. It really is a privilege to be able to be a part of the community and Like I said, we love the people here.
Well, good.
And it's been our pleasure. And we've enjoyed it a lot, and just we'll keep going.
Yeah, good. Well, you stay in there, and we hope to cross paths with you, maybe out in the social aspect. Maybe not so much.
Professionally.
Yes,
That's fine.
But you are a great resource. We do need to get those colonoscopies done, because anything you can prevent is so much better than as I said, the repercussions of it. Thank you for joining us today.
Of course, my pleasure.
And I'll say thank you to our audience. We hope you found today's show very helpful and informative, and we invite you to come back again next week for more Take